Thank you, Hélène, for this presentation. My conflict of interest. Anyway, I will not speak about medication today. When Stéphane Eliès contacted me to speak, to propose a topic for a talk, I said to him, well, I teach public health, so I propose to speak about public health. He'd say, oh no, public health, there will be nobody, this is boring, there are statistics, no, you should show something else. And so we decided to use the title, Why Child and Adolescent Psychiatry are repulsed by public health and why they are so wrong. Of course, I have indeed a conflict of interest because this is my specialty. But anyway, I have the feeling that he is right. I have the feeling, for instance, that in cardiology, colleagues have less problem with public health issues than in child and adolescent psychiatry. And perhaps you would say, yes, but of course in cardiology there is cholesterol, obesity, sedentarity, hypertension, and there is a need for prevention, and of course you have to deal with public health issue. But as soon as you say that, immediately you realize that in child and adolescent psychiatry this is exactly the same thing. Prevention is a major issue, prevention of childhood abuse. We know that child abuse is a huge risk factor for children, adolescents and adults. And so we have to deal also with public health issues, and perhaps even more than cardiology. And so why this difference? So just one slide, because the explanation, why are we not so interested in public health? The definition of public health, of course you know that. Public health, you deal with health issues at the population level. And so this is important for health service, prevention, evaluation. And there are some specific problems with mental health. We are going to do that, to see that, and I will try to be a little bit short so that you will have the possibility to ask questions. We are here to exchange. So why are we repulsed by public health? First point, you know, people dealing with public health are dealing with average subjects, average patients. This is because of statistics. When you do statistics, you are dealing with average subjects. And indeed, no patients in real life are like average patients, but that's life. That's life. In our specialty, what is much more problematic is that we are not most often dealing with, not with children or adolescents, but with the family. And you know, there is no average family. This is impossible to conceptualize an average family. It is so complex relationship between a mother, a father, sister, brother, and the patient, and the grandparents, etc., etc., etc. So this is very difficult to conceptualize an average family, and so perhaps we have the feeling that statistics do not apply correctly to child and adolescent psychiatry. The other point is quite a crazy syllogism. You know, for many people, public health is related to money. And in fact, it is true. And child and adolescent psychiatrists don't like problem with money, you know. Why? Because life has no price, and life of a kid has no price up to square. And so we should spend all what we can to protect our youth, because this is our future. This is most often what we feel. And so if public health professionals speak with money, at the end, this is not our problem. Money is not our problem, even if we know that money is a problem in most countries. Perhaps there is another explanation, the classical opposition between the spirit of finesse and the spirit of geometry. I will say it in French because this comes from Pascal and we are in Switzerland. Esprit de finesse et esprit de géométrie. It is supposed that some people are closer to poetry, to things that are refined and subtle, and other people like things that are very squared. Some become professor in literature, some become professor in mathematics, etc., etc. And perhaps among physicians, those who chose to become child and adolescent psychiatry could be closer to the spirit of finesse than the spirit of geometry. This has been said. A problem of superego. Why? You know perhaps that it has been written that mathematics, statistics are a kind of superego, because 2 plus 2 is equal to 4, and you have nothing to say about that. This is the law. And some people do not stand that there are laws in the existence. This is people with problem of superego. And you know that kids that have problem with mathematics, this is not necessarily because of a cognitive problem. Sometimes it is a problem to deal with superego. And perhaps child and adolescent psychiatrists have problem with superego, who knows? And so they don't like figures. We often say that there are very few data in child and adolescent psychiatry, so this is not possible to do public health because there are no data. In a way, this is somewhat true, because we have patients from 0 to 1, 1 to 5, 6 to 12, 12 to 20, and they are all different. So we have to do studies in all ages. And you know, ADHD is not completely the same between girls and boys. So we have to do subgroup studies. And so, because we are not so much money to do research, and because we should do research in all age, at the end, we have not so many relevant data. This is a real problem. But to be honest, more and more now we have data, and we are going in a couple of minutes to present this data. These data do exist nowadays. So, of course, there are less data in child and adolescent psychiatry than in cardiology. I agree. This is true, and this is a pity. But data do exist anyway. Some colleagues also say that data are misleading. You know, data are numbers. And do numbers really grasp the complexity of a child or an adolescent or a family with a mental health problem? Of course, not completely. And so because of that, data are misleading, and thus public health is unfair. This is, you know, many colleagues have the syndrome of the ugly duckling. They cry because everybody, money go to cancer, to cardiology, never to us. Nobody understands what we are. And we are treated kids, and we should be the priority, but we are not the priority. This is unfair, and we are crying. And after, perhaps, you know, perhaps cardiology, they can deal with public health issue because they have no more problem with their underlying theory. You know, they have the heart, the vessels, the blood pressure, etc., etc. There is a consensus all over the planet about what is the heart and how it functions. And so, because of that, they can teach to their intern, to their junior doctor, the physiology of the heart. And once it is done, they can do public health. We are not at this stage, obviously. We have many, many theories, neuroscience, psychoanalysis, etc., etc. And this is very difficult to have the global picture on a theoretical point of view about what is a child or adolescent patient. And because we are fascinated by theory, because we are human beings, we stay to think about theories, and to discuss and to determine which is the best theory at the moment, and we forget that there exists also public health, which is rather neutral in terms of theory. So this could be the explanation why child and adolescent psychiatrists are repulsed by public health. Why they are so wrong? They are so wrong because this is a personal point of view. My belief is that at the moment, if a child and adolescent psychiatrist has to be considered as a smart person, this person should speak the language of neuroscience. This is unfortunate. You can consider this is unfortunate, but that's life. If you are a neuroscientist, you are somebody very serious. But if you want to be convincing with health authorities, with politicians, you have not to be a neuroscientist. You have not to be a psychoanalyst. People will say, well, you are highbrow, congratulations, but if we want to speak about money, organization of healthcare system, this is not with you that we will discuss. If you want to be convincing with politicians, with the director of your hospital, you have to speak about public health. And so if we really want to do some advocacy or our specialty, we have to speak the language of public health. If we say nobody understands what is child and adolescent psychiatry, this is in part our responsibility. We have to speak the language of other people. And this language is about statistics, cost effectiveness, and etc. And so we have to do public health. So I will tackle very quickly two topics. First, I will try to answer the question, should child and adolescent psychiatry be a public health priority? And the second, what should be the organization of health service according to countries, of course, because this will not be the same in all countries. So the good news is that now data do show that child and adolescent psychiatry should be a priority. This is the good news. We have data to say that. And we are in Geneva. You know that WHO is very close to Geneva. And even if I don't always agree with WHO, they did the job. In the past, child and adolescent psychiatric disease were mixed with neurological disease, etc. And nobody could determine what was the weight of child and adolescent psychiatric disease. And nowadays, we have an evaluation of the global burden of disease due to child and adolescent psychiatric disorder. How it is done? It is done with DALYs. I'm sure you all know the concept. I just say it very quickly. DALYs, you know, for a long public health impact of disease was just the number of years of life that were lost. And so of course cancer and myocardial infarction was overestimated because this disease kills. And of course psychiatry, there is suicide. But for autism, for schizophrenia, for depression, people live along and they suffer along. And it was not present in the number of years of life that were lost. And so people have added number of lost years due to ill health, disability, or early death. And so how is done the computation? For instance, if you have a 16-year-old adolescent who commits suicide at 16, what is the number of days that is lost? The adolescent is supposed to live up to 80 years, so he has lost 64 years of life, and so he has lost 64 days. If it is a 7-year-old child which is diagnosed with ADHD, how many days will be lost? And this is the reason why we have to be aware about public health issue. How do they do the estimation? They do the estimation considering that in average ADHD, the duration of ADHD is 25 years. Why? We all know this is not really true, but we know now that in adult patients, most of them have also ADHD. They consider 25 years, and they consider that the fact that you have ADHD has an impact on your life. This impact is come from 0, no impact, to 1, you are dead. And ADHD is supposed to be 0.014. So very close to normal life. You have all meet already kids with ADHD. Many of them have a level of disability which is very important. And so if we want to be heard, we have to discuss this issue. Anyway, this data exists. And what are the results? In red, you have mental disorders. You can see that in Africa and in some part of Asia, infectious diseases are very important, of course, malaria, etc. Of course, in Africa at the moment, infectious AIDS are still very important. But look at here in Europe, and in America, what is the more important? Mental disorder. In the age or 5 to 14. So we can say, and it is data from 2014, we can say today that we have data which show that the most important global burden of disease in this age comes from mental disorder. Of course, life is never simple. And we have data in 2015, and nutritional disorders are now more important than mental disorder. This is crazy. What has changed in 1 year? They have considered that, in fact, depression in adolescents and in adults was not so important as they consider it was in the past. And so the number of DALYs has decreased because depression is no more considered as an important problem. On the contrary, anemia due to loss in iron, you know what I mean? Problem. Sorry? Iron deficiency anemia. Thank you. Is becoming a huge public health problem in Europe and in Northern America. There have been papers just after the publication of this result which say that this is crazy, but if we want to be heard again, we have to know how these figures are obtained in order to be able to criticize them. And I can enter a little bit in detail how this 0.014 has been obtained in practice. They have selected 10,000 people with internet survey or face-to-face survey in different countries, people without any disorder, adult people without any disorder. And they have asked, consider person 1. This is a young patient, hyperactivity, which means that he has difficulty concentrating, remembering things, and completing tasks. And person 2, I describe a patient with the same age and with chronic asthma. And I say to people, who do you think he says is healthier overall? The first or the second person? And according to the percentage of person 1 and person 2, you obtain the number, this coefficient, which determines the number of DALY. But this is crazy because this is not the real definition of a patient with ADHD. This is only the syndrome. The day-to-day life of a patient with ADHD is stigma, is the fact that he has no friends, that the teacher put him or her in the back of the classroom, that even his parents become bored because of all this hyperactivity, etc., etc. This is the real life of a patient with ADHD. This is not that. And so, of course, when people are comparing the two persons, the number is not correct, you know. But and this is the reason why child and adolescent psychiatrists have to learn public health, because people who do these studies, they are public health professionals. Some of them are child and adolescent psychiatrists, but they have not seen patients for long, and so they forget what is a real patient. So you have to say that this is not correct. Okay, and even more, you know, in this computation, there is no caregiver burden. And you know that in autism, anorexia nervosa, ADHD, the burden of disease is at least as important in the parents, in the sister, brother, than in the kid. Now, about health service organization. I am sure that in most of your countries, there is a crucial question: how many child and adolescent psychiatrists, psychologists, nurse, social worker, teacher, educators, beds, etc. should we have for 1 million of youth? Everybody is asking this question. And we have no answer to give. And we should, if we want to have money, we should have answer to give to that. So I am going to try to give an answer. And you will see that the problem is a little bit more complex than it could appear. I have looked at science. What says science? The best epidemiological studies, on my point of view, that has been done to estimate prevalence of mental disorder in adolescents. I take adolescents. This is the NCS Replication Adolescent Studies, published in the Journal of the American Academy in 2010. What are the figures? About 50% of lifetime prevalence of mental disorder in adolescents. Mental disorder, clinically relevant. Clinically relevant. Okay, so I did a small computation for my country that I know better than other countries. We have 5 million of adolescents. And so a given year, because of this figure, we have approximately 400,000 adolescents with a mental disorder. If we take anorexia nervosa, schizophrenia, depression, anxiety, general anxiety, OCD, etc., all these disorders require some kind of psychological treatment. I think you will agree. So, we will have to propose evidence-based psychotherapies. Okay, if the disorder is mild to moderate, about 10 sessions. If it is very severe, perhaps 30 or more sessions. But you know, a psychologist in France, like everybody, is supposed to work 35 hours a week. Among these hours, there is time for supervision, etc. And so if you do the estimation, we would need to treat all these adolescents, about 10,000 psychotherapists, and in fact in France at the moment there are 10,000 psychotherapists. And so if we follow evidence-based guidelines, if we follow data coming from the best epidemiological studies, all psychotherapists in France should be dedicated to treat adolescents. And of course, this is not possible. This is not possible. So colleagues will say, well, there are not enough psychotherapists. We should have more. But you can imagine, we should have 10 times more to treat everybody. And this is not sustainable. This is not sustainable. And this is why I say here, what happens in practice? In practice, we try to treat optimally only the patients that we see, the patients that we have in consultation, because we see that they suffer, and we propose to them the best that we know, that is evidence-based treatment, and we are right to do that. But at the same time, we don't see that there are many, many, many youths that have exactly the same problem, and they do not come to see us. And I often feel guilty about that, you know. After my day of consultation, sometimes it happens that I have done a good job. I have done a good job with the patients that I have seen today, not with all the patients that I should have seen and that are alone with their parents at school. So, in fact, we have to acknowledge that, for instance, the best randomized controlled trial perhaps done in child and adolescent psychiatry in ADHD is the MTA study. In the MTA study, there was a psychological treatment for patients that was efficient. But it was so wonderful that in practice it is impossible to propose this treatment to all kids who have ADHD. This is not sustainable, even in Switzerland, and likely even in North America also. So in most countries this is not possible. So what can we propose? Because we have to propose things. I find that there are two problems. The first problem is that the prevalence that I have shown to you is not correct. There are not 50% of adolescents who have a mental disorder in their life that is clinically relevant. This is crazy. This is not true. Why this is not true? Because psychiatric epidemiology is not what it is supposed to be. Psychiatric epidemiology is not designed to give prevalence of mental disorder. Psychiatric epidemiology is good at giving risk factor, but not prevalence. Why? Because there is a huge difference between what we experience during our consultation. When we have a consultation, patients come to see us. If they come to see us, This is very likely because there is a problem. There is a problem that makes that the consultation happens. While in psychiatric epidemiology, people go to see subjects. And so you can find many subjects in the street who have psychiatric syndrome. But anyway, they live. Their life is correct with their syndrome. You know, that's life. This is not because you have a psychiatric syndrome that you are a psychiatric patient. And so the tricky thing is to make the difference between a person with a psychiatric syndrome and the patient that should be treated. And I am not alone to say that. Spitzer, you know, a very famous American guy that was at the origin of the DSM-3, some person very wise, has written a paper in the Archive of General Psychiatry in 1998. Diagnosis and need for treatment are not the same. And epidemiology give diagnosis, do not give need for treatment. And we need need for treatment to do health, to do public health. Some people, epidemiologists, try to deal with the problem taking into account impairment. You know, if there is a syndrome and impairment, so there is a psychiatric patient. But take adolescent with anorexia nervosa. Most often there is no impairment. And they can be very severe patients. And anyway, why impairment should be the main thing to consider that the youth needs some treatment? You know, why impairment? This is a little bit shocking, you know, because impairment is related to functioning, is related to productivity. Why not suffering? Suffering related to the emotions that are painful for you. So still we have not good way to determine what should be added to the syndrome to make a psychiatric patient, and we have to think about that because we have a major issue to fix at the moment because of this blur. People speak about mental health, psychiatry, disability like synonym. And of course, if all psychiatric patients are in fact subject with mental health problem, is it really necessary to have child and adolescent psychiatrists that cost a lot to do their clinics? Perhaps social worker and psychologists could do the job, you know. And you know that many politicians have this in mind. And so we have to answer to this question, because we are on the field. And we know that some subjects, some youth do need a contact with medicine, and some other not necessarily. Advice with the school, with the parents, non-medical advice could be enough. And this is a tricky question. Who should be treated by whom? And with which money? Of course, because society has to pay after. I know that there are papers who say that healthcare system should be divided in level 1, level 2, level 3. Level 1 is a primary care, level 2 is a specialist, and level 3 is university department, etc., etc. This is the beginning of a reflection, but this is not enough. This does not deal with the very difference that exists between mental health and psychiatry. And we have an opportunity here in child and adolescent psychiatry. We can take the lead because perhaps you don't realize that somatic medicine has exactly the same problem. For instance, the prevention of type 2 diabetes, of myocardial infarction, deal with the prevention of obesity and overweight. And for many people today, the question of obesity is no more a medical question. This is a question of stigma, of difference, and anyway, physicians can't do anything about obesity. This is impossible to treat, you know that. I exaggerate. But this is very difficult. And so many people consider that overweight is a problem of health, not of medicine. We should take it, we should manage it in a different way. And so somatic disease, somatic medicine has the problem, and we have it even at a larger extent. And so this is our responsibility to take the lead. I think this is my last slide before the conclusion. The other problem is that I have the feeling, you know, when a big pharma develops new drugs, the pharma does a marketing study. What is the prevalence of the disease? What are the drugs already available? Is the society ready to spend a lot of money in this disease? And if the answer is yes, then they are planning the price of the medication according to the effect size they are expected. And we do not do the same thing with non-pharmacological treatment, and we should do that. We should do that. And people already do that. A very good friend of mine, Jean-Nicolas Desplan, who lives in Switzerland, he is a psychoanalyst, and he has evaluated. I think that in Switzerland you have the possibility to propose to all patients 1, 2, or 3 sessions of psychotherapy, whatever the question. No, this is more or less true.
I don't know what is the question.
Well,
we have a lot of freedom, I guess, to propose some session, and we have the opportunity to propose 2 or 3 sessions.
Yes.
Week.
Yes.
Yes.
So there are some countries where health insurance can accept to reimburse 1, 3, 10 sessions of psychological treatment. And so we should develop psychological treatment adapted to this proposal. You know, if 5 sessions are reimbursed in my country, I have to design 5 sessions psychological treatment, because this is reality. This is what I can propose to kids. And so this is reality, principle of reality. So you will say this is crazy. This cannot work. A psychological treatment, you need 30 sessions, etc. And Jean-Nicolas Desplan did randomized in adult psychiatry. Okay, he did randomized control trial with psychodynamic treatment with only 3 sessions. And it is better than a control group. This is evidence-based. And so you can say after to health insurance, you offer me 5 sessions, I offer you this treatment, this psychological treatment, so we can do the deal. We can do the deal. This is a way to go forward. And there is a new concept. You all know evidence-based medicine, evidence-based practice. There is no practice-based evidence. This is a concept very appealing, where the notion of evidence is turned. We should take into account the reality first. And once you have taken into account the reality, on this reality you can design treatment and you evaluate this treatment with good methodology. And this is my conclusion. So obviously I hope that you will have seen that population level analysis is a necessity in medicine, and this is even more important in child and adolescent psychiatry, because the notion of group is everywhere. You know, we have to deal with a teacher, with social worker, with judge, with psychologist, etc. So our way of thinking is a collective way of thinking. If we want to do advocacy, we have to use the vocabulary of public health. And stop crying, stop feeling the ugly duckling. We are not so desperate. People appreciate what we do. And we do a good job, and we have to say that we do a good job. And we have to show to people data that come from our study. At the moment, there is a huge movement that puts care out of medicine. You know the sociology of care, philosophy of care, that considers that we should deal more with vulnerability of people, and this is not a medical concept. Vulnerability is a philosophical concept, and I think this is good for us, our society, to deal with this philosophy of care. But because of that, there is a tension between medicine and care. And we have to find the border, and this is typically a clinical question, when does the patient should be relevant for medicine and for child and adolescent psychiatry, and when does this patient should just benefit from advice for his day-to-day life. And of course, you know, the border is blurred. This is a gray border. Many kids can be in one part or in another part, but we have to think about that to explain to politicians where to put money. And don't be afraid of statistics, because in fact statistics are not a problem of public health. This is a question of group level thinking, which is the core of public health, and this is typically our way of thinking. I thank you for your attention, and I would be pleased to answer to your question.